Immuno-oncology, as we understand today, is the direct interference enabling the immune cells to attack the tumor, that overcome the blocking mechanisms that was produced by the tumor. One has to imagine that all cancers have a lot of mutations, they're abnormal proteins, and the body recognizes them as foreign. Everybody develops cancer all the time, and the immune system gets rid of it. However, the tumors have developed mechanisms that they can fight off the immune system. And they can find ways by secreting factors which block the immune cells, or by having on the surface receptors, which when the immune cells hit those receptors, they go inactive. Now, immuno-oncology is the idea to enable the immune system to fight back the cancer directly. Essentially, there's two ways, big ways to do it. One could take immune cells, we call it T cells, out of the body, culture it, and give them the capacity back to fight the tumor directly. The other way is to use monoclonal antibodies, that's proteins that are infused, and these proteins inhibit the blocking between the active T cells and the tumor cells. You know, immuno-oncology is not one treatment. It's an array of different opportunities to enable the immune system to fight the cancer. Why hasn't it done before? Because the science hasn't been as advanced. So if we talk about advanced cancer, metastatic disease, the classic treatment modalities was chemotherapy. And then with the advances in molecular biology over the last 10 years, it became possible to identify certain pathways in tumors that could be treated by specific drugs, which are not chemotherapy, but really blocking specific pathways in the tumors. And this has been a great advance. And now on top, immuno-oncology provides even further opportunities to treat the patient. Activity in cancers that we have not seen by conventional means in those type of diseases. Over 20% of patients with advanced melanoma have benefited continuously over years. What we deal with in survival curve. So we have on the x-axis the time, on the y-axis the proportion of patients alive. And it looks like following. It falls down and then it plateaus at 20% for years. And we don't know if it's going to be 10 years or not. But this plateau is indicative that something dramatically happens, because it does never happen with other treatments. This gives the idea that the tumor and the immune system are in equilibrium, or in some patients the tumor is gone. It's exciting science and very promising for patients. It really will change the practical field of medicine for a medical oncologist in the future. They have to learn a lot because the side effects with immuno-oncology are different. They require new skills and new training. Some of the treatments can have quite severe side effects with diarrhea or endocrine disorders that need to be managed. And then you could say, yes, but what is the benefit? But if the benefit is you have a metastatic disease, you have some side effects, but you can live for years, you know, I would think most patients would agree to have some side effects. There is a need to improve the outcome of patients with cancer, and immuno-oncology has a new avenue, gives a new avenue. Of course, it will not, to my opinion, replace what standard of care is by now. It will be an addition. So there will be, of course, also an additional burden financially that has to be dealt with. Public authorities first have to realize there's something new coming, and we have to be aware of. Clinical research is a difficult topic. There's a lot of hurdles to protect patients, but there is also a lot of hurdles that you sometimes can question that they hindered advancement. So I think facilitate clinical research is certainly a very important topic, particularly in Europe. There have been academic institutions which have made a tremendous impact, and this has been particularly in regard of using the T cells or the so-called dendritic cells for the patient, cultivate those cells out of the body, change them in a way that would attack the tumor and give it back to the patient. The question though is still also for those institutions, if they have developed a very good method, how can it be produced for a whole population? You know? A European challenge is the equality of access. Immuno-Oncology is for the most of the part clinical trials, but there have been agents, immune checkpoint inhibitors, that have regulatory approval for clinical use. The thing is, though, the results are good, but there is so much more hope for better results that I would think most of the physicians or centers that deal with immuno-oncology would like to treat the patient in trials to give him even a better chance than what is already available. For everybody, it generates hope. And we have to be careful that we don't exaggerate, but the hope is there. It's seeing the long-lasting responses in patients with advanced cancer and the benefit of the treatment can have. And this is why we're physicians, that's what we work for.